Thank you very much, Kathy, and welcome everyone. It's amazing to see so many people, indeed, not only from Ireland, but indeed from all over the world to join this information session. I really do want to thank the All-Ireland Institute of Hospice and Palliative Care, because their support in assisting me get these off the ground has been absolutely phenomenal, and I wouldn't have been able to do it without that support, so thank you so much. I also want to thank our panellists that we have today, and we will be running a series of further sessions on probably a bi-weekly basis, and that's addressing the issues that is coming through on the questions that people are submitting. So we have another session on Thursday looking at how we support somebody who needs to be in isolation. But for this morning, I really want to introduce our main speaker for today, and that is Dr. Regina McQuillan. Regina has a lot of experience in the field of intellectual disability, and we're really grateful for her input, not just today, but indeed over many years. Has been a fantastic support. And Regina is a palliative care consultant at St. Francis Hospice in Raheny and Beaumont Hospital. So I'll hand over, Regina, to you now. Okay, thank you.
Thanks very much, Mary. So, and thanks very much for the opportunity to present here. And I'm just going to get my slides up and running. And then you'll be right. So, my topic this morning is about advanced care planning, and I plan to talk for about 25 minutes or so and then leave time for some questions. I suppose when we're talking about advanced care planning, it's a plan that's made when somebody is competent about the medical treatment which will come into effect when the patient loses capacity. I'm aware that there's quite a number of people from outside the Republic of Ireland at this presentation. I am going to be talking more in terms of what might be recognised either legally or ethically within the Republic of Ireland, but I think the principles are very much the same regardless of what country that you work in. So the Medical Council of Ireland recognises advanced care plans as being important and valid, and the AIIHPC consent policy of 2016 would also recognise the importance of advanced care planning. So even though there's no legislative framework in Ireland in relation to advanced care planning, they are recognised as being things which would be appropriate, to be ethical, and if there was case law, would also be respected. So an advanced care plan or directive has the same status as a current care plan, provided that the request or refusal of treatment was an informed choice, the decision covers the situation that has arisen, and there's nothing to indicate a change in mind. So a person who is able, while competent, to make a decision whether or not they want to go to hospital, whether they want to on antibiotics, if they're able to weigh up the pros and cons of those decisions, if they're able to understand that information, apply it to themselves, weigh it up and convey a decision, that would suggest they have capacity to make a current care decision. And similarly, if they are able to make an advanced care decision, that they're able to take in the information, to weigh up the information, to apply it to themselves and convey a decision, that would suggest they could also have capacity to make an advanced care plan. They say it has the same status as a current care plan. In advanced care plan or directive, there's no obligation on a healthcare staff or doctor or nurse to give treatment which is not clinically indicated, or to give any treatment which is futile. But if there's any doubt about the existence of an advanced care plan, and this is a statement from the Medical Council, if there's any doubt about the existence of an advanced care plan, or does it exist, is it valid, doctors should act in the patient's interest. They should try and establish, if anyone's the legal authority, to make a decision on behalf of a person who doesn't have capacity, and consult with the healthcare team and the patient's family if possible. So if there isn't an advanced care plan, it's not clear that there is one or not, in that situation, doctors have to try and make a decision acting in the patient's best interests. The Medical Council recognised the importance of advanced care planning, and in the later guidance in 2016, although it had been in earlier Medical Council guidelines, in 2016 the Medical Council extended the recommendation, saying that a doctor should do their best to help and support a patient to make an advanced care plan, and that also doctors should ask patients with long-term conditions or who may lose mental capacity or die in the foreseeable future if they've made an advanced care plan. So it's moving from the Medical Council recognising advanced care plan to the Medical Council requiring doctors to be more active in helping patients make an advanced care plan. As I mentioned earlier, the National Consent Policy, the AIIHPC National Consent Policy, also recognises advanced care plans. And in section 7.8, it said that patients may wish to plan for medical treatment in terms of future incapacity. There's no Irish legislation confirming the enforceability of such advance refusals, but it did also say that advance care plans should be respected on condition that the decision was an informed choice, the situation covers the situation which has arisen, and there's no evidence the service user has changed their mind since the advance care plan was made. Again, getting back to the idea, if there's any reasonable doubt the existence of an advance care plan, the doctor should act in the patient's best interests. I'm referring here to the principles discussed. These are principles which are discussed in relation to consent and capacity within the National Consent Policy. So if you're talking about advance care planning, these are maybe 5 questions you might be wanting to raise. What, who, why, when, and where. So what is an advance care plan? It can be very general or very specific. So an advance care plan that can be very specific about what treatment a person may or may not want in a very specific situation. Not everybody wishes to make plans such as that, and not everyone can envisage a sort of future with different situations. But I think it's important in those situations you have to consider what are somebody's values or beliefs. So what is important to them, what are their belief system, and that may help that if people state their values or beliefs, it can then help in a situation that the person doesn't have capacity for making decisions about their care. You can have specific healthcare decisions, including requests for particular treatment, or including refusal of particular treatments. The advance care plan may suggest things such as a preferred place of care, so whether somebody wants to be cared for at home or in a long-term care setting or in a hospital. And an advance care plan may also include a nominee for consultation. So in Ireland at the moment there isn't a possibility of having a healthcare proxy decision maker, but you may have a nominee for consultation. A nominee is somebody who might understand your wishes and a person with whom you can consult. So who should be involved in making an advance care plan? So it's about a patient, it should be the patient or service user's wishes. But if you're talking about this being an informed decision, I think it's really important that the information which is available that might be necessary to make an advance care plan is available to the person. So you may need people like doctors and nurses to give factual information about illnesses. You may need social workers or others to give emotional support, but also better information about where your preferred place of care might be. I think it's also important that you would include in these sort of situations the person's family, their informal carers, and also social care workers. They should be involved in discussions about advance care planning. So when should you do this? Now, usually, you'll be talking about making an advance care plan when there's been a diagnosis of an illness which is likely to be loss of capacity. I think one of the challenges in the intellectual disability population is that some people may have very limited capacity to make a decision at any time, but there may be people who are able to make decisions now, but they may have a diagnosis that in the future mean they'll be less likely to make a decision. And that, for example, might be somebody with Down syndrome who is been diagnosed with dementia. It could also be if there's a diagnosis of an illness where there's likely to be complications needing urgent treatment. So an example here, which is for the part of the general population example, we say people who have an illness that might develop respiratory failure, such as motor neuron disease, that they may, if that's likely to happen, it may be useful then to have a conversation with people about what would be important to them. People who have a diagnosis such as cancer, and if there's evidence of disease progression such as new metastatic disease, that might also be a trigger to think about advanced care planning. And I think the thing that sometimes comes up, particularly with people who are living with multimorbidity or frailty, is people having hospital admissions, repeated hospital admissions, or increasing intervals, or decreasing intervals, increasing frequency of hospital admissions. So it's not that somebody has a very specific illness, but it may be that they're now running into situations of having recurrent infections, recurrent aspiration pneumonias, and that might then be a trigger to consider is this person's overall health changing. So ideally, when you're talking about making an advanced care plan, you should be trying to make it in the person's usual place of care with usual supports. Ideally, you should be trying to make an advanced care plan in a calm setting rather than in the middle of a crisis. And the reason you might do this is that you're trying to respect the person's wishes. There's also the idea that you might be improving the patient's end-of-life care because you're giving better information about what's important to the person. It then provide clarity for professionals and carers. And one of the reasons which can be controversial about the idea of advanced care planning is the idea that it might reduce healthcare costs. And sometimes this is seen as a driver for advanced care planning, but we think we need to be really cautious about considering advanced care planning as a solution to healthcare costs. Because you do have that problem where advanced care planning doesn't answer everything. So sometimes there's some consistency of wishes, but it's not complete consistency of wishes about what people would want. And that's why an advanced care plan now when people are sort of quite well and there's no future anticipated problem, it can be very hard to say now what you might want in 5 years' time. Your wishes might change. There's also sometimes a suggestion that it undermines the idea of a doctor-patient trust, because does a patient need to write a plan now because they don't trust a doctor or the healthcare system to make good decisions in the future? There can be this concern about the institutional agenda is the idea of advanced care planning about reducing costs. Because there's sometimes a belief that everyone's going to choose not to go to an acute hospital, not to go to ICU. There are many people whose wishes would include transfer to ICU. And if a person copes by not thinking too much about their illness, copes by avoidance and denial, they may not wish to have an advanced care plan. They may not wish to think about a time when their health is going to deteriorate. And it can be undermining of the coping mechanism by suggesting doing an advanced care plan. So when you're talking about advanced care planning consideration, one of the things you have to think about is autonomy. The idea is of an advanced care plan is that you're trying to respect the patient's wishes. You're trying to recognize these people as an individual and what's important to them. The idea about people's capacity to make decisions does come into this concept of functional capacity. So can people make the decision that's required? And this can be quite a challenge because there sometimes are people who are very clearly able to make a decision now about antibiotics or about going to hospital for intravenous treatment because it's very much a here and now problem, but it can be more difficult to consider into the future what that might be and how to make a plan for a future experience, particularly if somebody has never had that experience of hospital admission or ICU admissions. There needs to be an informed decision. So ideally this is a decision which is made when people are able to give the appropriate information for the person. Really important that advanced care planning for an individual person is not obligatory. And but also in advanced care plan, you cannot oblige futile or unethical or illegal treatment. I think when we're talking about advanced care planning, here I'm talking about the situation where the person themselves is making a decision about treatment. But I do think we need to recognize that there will be situations where you may have people who do not have the capacity now to make a decision about their current care, and those patients may not have the capacity in the future to make a decision about their care. And that then can create some challenges then about how do you plan for future care. I'm going to talk a little bit about the rights of people with disabilities because particularly as we're talking about a session here for people with intellectual disability. So the Medical Council guides professional conduct and ethics for registered medical practitioners. There's this is addressed in a number of areas, and saying that doctors need to exercise clinical skills and judgment without allowing, among other things, disability to affect in a negative way the treatment you give. It also says that adults who are considered not to have a capacity to make a decision are entitled to the same respect for their dignity and personal capacity as anyone in full capacity. There's a paragraph about protection of vulnerable persons, and these are people identified with, among other things, disabilities, which means they cannot live independently. And also then saying as a doctor with a management role, you have a responsibility to advocate for appropriate healthcare resources and facilities if insufficient resources are affecting or may affect patient safety and quality of care. And I think that's a very important area for those of us who are working in the healthcare service in general. The Department of Health in Ireland has brought out an ethical framework for decision-making in a pandemic. And this is what they might consider a high-level framework. It's not talking about individual patient considerations, but it does cover, there's about 8 principles in total. One principle is about minimizing harm, and the idea of minimizing harm, there may be a requirement to restrict individual liberty, but also then with proportionality, you need to minimize the restrictions. Another principle is fairness, and the importance of recognizing the moral equality of all persons, and that people should not be discriminated against on the basis of age or anything else. And then also then the duty to provide care. So those are some of the ethical framework points from the decision-making framework produced by the Department of Health. And I suppose many people who are present will be aware of the United Nations Convention on the Rights of Persons with Disabilities. And in a number of articles, there are important points which are relevant in this scenario. There's the right to equality and non-discrimination. People with disability have equal right to life. Article 11 obliges the state to ensure safety. And Article 25 says that people with disability have the right to highest attainable standards of health. And I think when we're looking at a situation such as a pandemic, when you have, if we're looking at the idea of the right to high sustainable standards of health, we then have to try and balance that an individual may wish to have the right to high sustainable standards of health, but how is that balanced with the responsibilities for all people who are in a similar situation, rather than one person having more resources and therefore other people may be losing out because of that. So you could have a situation where there's two people who are living with intellectual disability who are living in a specific setting. If one person says that like all staff should wear PPE with them all the time, that means that there might be a lack then of personal protective equipment to protect other service users or other clients or other residents. So you may say that you may wish to have greater protection, but you have to then balance the risks of you getting excessive resources with what other people might need or want. So usually when you're talking about advanced care planning considerations, it's rarely urgent, because normally this is a situation people they have something that you recognize their health is changing, a new diagnosis of cancer, a new diagnosis of dementia, recurrent hospital admissions with repeat aspiration. And in those situations, there's normally not an urgency to make a plan. But because of the current COVID pandemic, there's a greater focus on advanced care planning. And I think there have to be two sides of this. This is not just advanced care planning for people who have COVID. This is advanced care planning for people who might need acute hospital admission. Because I think at the minute there's a big strong focus on COVID, and I think that's very important. But I think we also then need to sort of consider that all of our patients, all of our clients, we have to consider what is their health like. So if they were to get a COVID infection, what would be important, what would be possible for them. But also in general, if they were to deteriorate, what would be important, what would they need. If you're talking about advanced care planning consideration, you have to have the idea of, if you're writing a plan, it has to be fit for purpose, not so vague as to be useless. But if an individual person is only able to sort of contribute by having their values and beliefs, that's an important contribute. So it's just clear what is important to that person in relation to what's their values and what's their belief about their health. It should be documented in such a way that it should be available when needed. And in this situation, it could be like the healthcare passports that sometimes people with intellectual disability would have, that maybe advanced care plan should be part of the healthcare passport. And that you should encourage engagement with the patient's family. So, and I tend to use the word patient because I'm seeing people when they're sick, so I see them as patients, where I think a lot of people present are seeing people as service users or clients. And I think in a setting such as intellectual disability, where many people live in, say, social care settings, I think you have the biological family with whom people are related, but also I think you have the sort of the family network with whom they live, and that includes the social care workers with whom they live, who very often have a very good understanding of people's values and beliefs. So, moving on then to a statement of values and beliefs. And a statement of values and belief may be, what is it that's important to somebody? And this could be as simple as people may say, and it may be that people are able to say this clearly. I want to be able to be well enough to go out every day. I want to be able to talk to my friends. I want to be able to eat and enjoy food. Those can give us some ideas of what's important for people. And that can then, and for many people, their values and beliefs can be the best way of deciding what's important. Many of you have worked with people and do work with people who are able to state their values and beliefs clearly, but their values and beliefs might be very obvious, or what's important to them might be very obvious to the people who know them well. So you may be very clear that a person who has no ability to actually convey in words or writing or by using other sort of standard ways of communication what's important to them, but it might be very clear that they get very distressed when they go to hospital. It might be very clear that if they ever have to fast for a test, they find that very distressing. It might be very clear that they need to be able to, like, it's important that they're able to sort of sit out in their own chair. There are things like this which you can very clearly see what's important to that person about their social relationships, what they eat, what they do, how they spend their time, what clothes they wear. Some of these things can be, and these are things which need to be gathered from the people who know them well, and that might be their immediate family, it might be the social care workers, it might be other people with whom they live. You can then say you can have a specific statement about treatment refused, and you can have an advanced decision to refuse treatment. An advanced decision to refuse treatment, particularly if you're refusing life-prolonging treatment, it should be evidence that the person had capacity when they're making this advanced decision to refuse treatment. And so somebody, and I remember looking after an individual person once who had a delirium, had cancer, had a delirium, had intellectual disability. We wanted to check a blood test to see was her calcium high. She didn't want a blood test because she didn't like needles, but she didn't understand the concept of why you might need a blood test. And she did agree to having a blood test done so long as the doctor told her a joke. So I was very clear that this was not an informed consent process, but it was also very clear that in this person's interest to check a blood test to see was her calcium high and to manage her delirium, which we did check. Her calcium was high, we managed her delirium, and her condition improved. But it is that thing about when she was refusing an intervention, but didn't really understand the pros and cons of the intervention. And I think that can be just quite difficult depending on people's capacity. It can be difficult for them to understand the pros and cons, both about current treatment and about future treatment. In an advanced care plan, you can have specific statements about treatment which is requested. But you can't, although you might in a plan write down what you might request, you can't enforce treatment which is futile, you can't enforce treatment which is illegal, you can't enforce treatment which will unduly compromise the autonomy of others, and there also has to be the recognition of the fair use of resources. So in the same way that somebody who currently has capacity cannot, well, they can demand, but they can't, but nobody is obliged to give them treatment which is futile or illegal or an unfair use of resources. So if we think about advanced care planning, I think we have to consider this as part of current care planning. Ideally, it's done at the patient's request and pace, but with the new situation in relation to COVID, then maybe now we have to think more about advanced care planning with some more urgency than we normally would have. In Ireland, as I said, if a person doesn't have a capacity, there's no legislative framework to the government how a decision would be made. But then you need to make discussions then with the people who understand the person's wishes and their beliefs and their values. And these advanced care plans need to be done on behalf of the person and in the patient's best interests. And then it needs to be documented in such a way that this documentation is available when needed. So whether that's to out-of-hours medical services or if the person is going to hospital, that it actually transfers to hospital with them. So overall, what does it mean? You have to think about the possibility of advanced care planning. You have to think about the patient's questions about their health and about their future. Ideally, and I say we are slightly in this problem of we should be doing this not in a crisis, but we are sort of heading in towards a crisis. So we need to think about making those. We also need to remember that most people who get COVID, and that includes most people with intellectual disability, will get COVID and will survive COVID. So when we're talking about advanced care planning, we need to sort of recognise that there are people who will be supported well in the social care setting. There will be people who live in more medicalised healthcare settings who will be supported well there. But the decision is going to be then if people are in a healthcare setting, they have a diagnosis of COVID and their health is deteriorating, are these people who will benefit from going to an acute hospital? And what might acute hospital give them and will they benefit from that? And then when you're talking about doing your advanced care planning, you need to document in the chart or a health passport. And also maybe consider giving the person a copy of that, particularly people who are living independently, that they would actually have a copy of their own advanced care plan. So again, that they know that they were involved in this decision making. There are resources which are sort of like easy read versions of these, and I think Mary McCarran probably a better source of resources on that line. But I think when we're talking about people with intellectual disability, we're talking about a very wide spectrum of people's ability to engage in these. And I think we need to take this functional capacity approach. We're assuming that people have capacity until we're able to then see, do they have the capacity to consider, weigh up these particular decisions. So I'm going to say things very briefly. I'm not going to go into a lot of details about anticipated prescribing because I think there's a lot of people present who aren't healthcare workers, as in doctors or nurses, but also I'm just going to give you some links to particular websites. So anticipated prescribing is that you're prescribing medications now to be used if a person is deteriorating and likely to die. And these are medications to be used if life-prolonged treatment is not possible, if people are on life-prolonged treatment and this is failing, and for people who are clearly within the last days of life. And it's anticipated prescribing for symptom management to maintain comfort. The likely symptoms in COVID-19 are people may be breathless and also people will get delirium. And for any patient in the last days of life, the symptoms you're thinking of are breathlessness, delirium, pain, nausea and vomiting and secretions. But I say in COVID, breathlessness and delirium are the symptoms which are the most common. An important thing when you think about advanced care planning and people talking about people focusing on patients' comfort, you have to consider that is this person dying and are they dying, or is there any reversible problems? It might be self-evident that patients are dying and they're dying of COVID, or it might be self-evident that people are dying of a pneumonia and that interventions have been done to try and reverse this. But if people don't have COVID, is there an infection that's making them deteriorate? Is there renal failure? As I mentioned earlier, if people have cancer, are they hypercalcemic? There may be things which are reversible. And in these situations, they may need to have a medical assessment, and it can be difficult to access a medical assessment in a pandemic. You may be then depending more on out-of-hour services. And just around the country, specialist palliative care teams in general do not have doctors who assess patients at home. So most specialist palliative care teams are nurse-led and nurse-delivered. But if you're talking about anticipated symptom control for comfort when people are dying, you have to make sure that you're diagnosing dying correctly. You're assessing the comfort and symptoms. There are some non-pharmacological interventions for comfort, and that includes positioning, particularly for people with breathlessness. And there are two algorithms which have been produced by the HSE, one for as-required medications and one for syringe drivers. I'm not going to go through these in detail, but these are the links for those, and they're in the HSE Dr. Stevens library in the COVID section. And there's a section there that's particularly about palliative care, and that's where you'll find these resources. For people who are actually working, so people who are outside Ireland, you can find these resources, but they're actually based on the Scottish Sign Guidelines. So for people in the UK, you'll be very familiar with the Scottish Sign Guidelines. They're based on these, they're slightly different, but they're basically based on the Scottish Sign Guidelines. So as I said, I'm not going to go through them. The important thing is that if you're talking about prescribing, there's 4 drug classes for pain, breathlessness, secretions, nausea, anxiety, and delirium. You're talking about opioids for pain and dyspnea, benzodiazepines for anxiety or agitation, haloperidol and levomepromazine for delirium or nausea, and anticholinergics for secretions. You need to have these medications available ideally as a sub-cut form and an oral form. And that's where, I'll come back to that, but that's where about the drug availability is important. And if people have persistent symptoms, and it is possible to set up a syringe driver, there is an algorithm about using syringe drivers, but there may be a shortage of those, in which case then people might need to have regular 4-hourly drugs. The algorithm has use of syringe driver for people who are opioid naive and for patients who are on long-term opioids. So people with intellectual disability have multimorbidity, as Mary said in the last webinar. People are on medication to maintain health and well-being, and it may be essential to continue some of these medications, including anticonvulsants and for seizures and diuretics for cardiac failure. If people are unable to take meds orally, you might then need to think of alternate routes. And some of the anticonvulsants can be also given as a subcut infusion, or some anticonvulsants do come as a suppository format. An important thing is about the drug availability. So you need to have a prescription, you need to have the drugs available and storage. Long-term care settings and nursing homes, they don't carry drugs, so drugs have to be prescribed for an individual patient and available for individual patients. And for people in social care settings, if the drugs are prescribed, are they available, where are they kept safely, and who's in the situation that can administer them. And it's really important if patients have a diagnosis of COVID and it appears that they have been to hospital and are deteriorating and going back to their normal setting, or people who are in their usual setting and they're not going to be going to hospital and appear to be deteriorating, you need to liaise early with your community palliative care team. Thank you.